Let's go through the answers to the warm-up review. First question, what's the classic presentation of amyotrophic lateral sclerosis, or ALS, sometimes known as Lou Gehrig's disease? Well, ALS causes both upper and lower motor neuron deficits with no sensory deficits. And then the last question, what are the classic signs of an upper motor neuron lesion? So with an upper motor neuron lesion, you're going to see spastic paralysis and hyperreflexia. And then with a lower motor neuron lesion, you're going to see flaccid paralysis, muscle atrophy, and fasciculations. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on anesthetics. It's time to turn down your propofol drips and pay attention. Let's get going. All right, so in this video we're going to talk about anesthetics, and there are three big groups of anesthetics that we're going to talk about today. Inhaled anesthetics, IV, and then local. Now, there are three main components to general anesthesia. There's amnesia, analgesia, and immobilization. Now, amnesia means the patient has no memory of the surgery, no memory of being intubated and prepped or any other events related to the procedure, so they are knocked out. Analgesia means pain control. So surgery is painful, we're cutting them open, you don't want them to feel that pain. And then immobilization or paralysis is important because in order to perform a procedure correctly, you need complete immobility in that working area. So as we talk about anesthetics, we'll talk about how different drugs achieve these different aspects of amnesia, analgesia, and immobilization. Now first, let's go over some basic pharmacological principles about inhaled anesthetics. So in order for an inhaled anesthetic to work, it must be able to cross the blood-brain barrier and get into the brain. So there are two characteristics of each inhaled anesthetic that you need to consider: lipid solubility and blood solubility. Now the higher the lipid solubility, the easier it is for that drug to get into the CNS, into the brain, so you can get more effect with less drug. So the higher the lipid solubility, the more potent the drug is. So you can achieve anesthesia at a lower concentration. Now, blood solubility affects the amount of time it takes for a drug to start working, and drugs with low blood solubility will have a rapid onset of action. So I think of this as not getting stuck in the blood or getting mixed in with the blood, being able to move out of that blood into the brain more easily. And then the next concept to discuss very briefly is the MAC, the minimum alveolar concentration. So the MAC is the concentration of inhaled anesthetic that is needed to prevent movement in 50% of patients after a painful stimulus. So how much does it take to get 50 of those people to be knocked out? All right, so now let's use these concepts and look at some inhaled anesthetics. So inhaled anesthetics are used very commonly for both the induction and maintenance of general anesthesia, and that induction is just getting them asleep, and then maintenance is obviously keeping them asleep. Now, the precise mechanism of action of these drugs is still really not fully understood. We know that they affect multiple things in the CNS, like GABA, like glycine, like glutamate. Nitrous oxide is thought to work primarily by blocking NMDA receptors. So let's go through a few of these in more detail. So first, let's talk about nitrous oxide. It's been used for a long, long time. It enters the brain rapidly because it is very insoluble in the blood. So it has no trouble getting out of the blood and into the brain. Nitrous oxide has a rapid induction and a rapid recovery time. It gets in and out of that brain very quickly. However, nitrous oxide is not very lipid soluble, and as we said before, this makes it less potent. It's not a very strong medicine. Now, nitrous oxide is not used alone very often, but is often used in combination with other inhaled anesthetics like sevoflurane or isoflurane. Let's move on to halothane, the granddaddy. So halothane, on the other hand, it's going to be more soluble in the blood, which means it's less of it is going to be available to the brain. So it takes longer for it to reach the desired effect, and it takes longer to recover. Now, there's also a risk of hepatotoxicity with halothane, so halothane is almost never used anymore. Now, desflurane and sevoflurane are the potent inhaled anesthetics with pretty similar solubility profiles to nitrous oxide. Now, sevoflurane is used very often, especially for induction of anesthesia, and overall it's probably the most used inhaled anesthetic. And then in the middle of the road is probably isoflurane. It has a slower induction and recovery compared to sevoflurane and desflurane, but much faster than halothane. Let's move on to our IV anesthetics. So IV drugs used for anesthesia, which include medications that are referred to as sedative hypnotics most of the time. So these drugs induce a state of complete unconsciousness, but do not provide analgesia very well. So this would include drugs like propofol, thiopental, adjuncts like the benzodiazepines as well. So let's start with propofol. So everybody has heard of propofol since the death of Michael Jackson. Now it's sometimes called milk of amnesia because it kind of has a milky white liquid substance look to it. Now, propofol is an IV induction agent that works by increasing GABA in the CNS, so much like the benzodiazepines. Now, it's an extremely popular drug to induce anesthesia because of its rapid onset. It works within about 15 to 20 seconds, so super fast. Now, after that initial induction dose, it redistributes from the brain to the rest of the body, and then its effect starts to wear off over a period of about 5 to 10 minutes. But if you start an IV propofol drip, you can also use this drug to maintain anesthesia. Now, propofol has a rapid recovery due to that rapid distribution. It's getting into the brain very quickly, and then it's going to redistribute to the rest of the body quickly. It also very rapidly metabolizes to an inactive metabolite by the liver. Therefore, when you stop that IV maintenance infusion, its effect is going to wear off within about 20 to 40 minutes. Now, another thing to know about propofol is that it has a very high triglyceride content. So you wouldn't want to have a patient on propofol drip for days and days and days. Now, you might have a patient in the ICU that's on a ventilator on propofol for maybe a day, maybe two, but any longer than that, you're going to tend to elevate the triglyceride levels, which is going to increase their risk for acute pancreatitis. Let's move on to ketamine, another medication that we need to be familiar with. Ketamine is actually a PCP analog, and it's used for a variety of things, including analgesia, conscious sedation, induction of general anesthesia as well. Now, it's commonly called a dissociative anesthetic, where the patient actually kind of seems to be awake and aware, but is totally disconnected to the outside world. Now, at high doses, it may cause hallucinations as well. Now, this is more problematic in adults than in children. Children tolerate it a little bit better. Now, at low sub-anesthetic doses, it does provide analgesia without the severe hallucinations or those real vivid dreams that are also associated with ketamine. And you should also know that ketamine increases cerebral blood flow as well. Now, barbiturates, on the other hand, tend to decrease cerebral blood flow, which makes them useful for brain surgery, where a decrease in ICP is often important. And speaking of the barbiturates, let's talk about them in a little bit more detail. And we'll also compare them to benzodiazepines. They're kind of similar, but a little deceptive there. Now, a lot of barbiturates have the suffix barbitol, like phenobarbital, pentobarbital, secobarbital. There's also one called thiopentol as well. Now, all of these work by acting on the GABA receptors in the CNS. Now, GABA, as you probably already know, is the primary inhibitory neurotransmitter of the CNS. Now, the GABA receptor has a chloride channel, and when GABA binds to its receptor, the channel opens and chloride ions are going to flood into the postsynaptic neuron and stabilize the membrane potential, making it harder to produce action potentials. Now, barbiturates are going to work by keeping those chloride channels open longer. They increase the duration of that GABA receptor chloride channel staying open, and that facilitates the inhibitory effects of GABA. And when you inhibit the brain, you're causing sedation. They can also be used as sedatives to decrease neuronal firing and lots of other scenarios as well, like even seizure disorder. Now, sedation and CNS depression can also cause a lot of side effects. It's going to look a lot like someone who's been drinking a lot, who are drunk. They're going to be kind of sluggish. They might have an ataxic gait, maybe even double vision. So how do we treat an overdose or a toxicity of barbiturates? Well, there's actually not a great antidote or reversal agent to treat barbiturate toxicity. We simply have to treat it symptomatically and keep people alive. Now, one other interesting use of phenobarbital, which we'll probably discuss in the GI videos on the hepatobiliary system, is that phenobarbital can increase liver enzyme synthesis, also known as enzyme induction. And that can be useful in treating something called Crigler-Najjar syndrome type 2, where the liver is deficient in the enzymes needed to process bilirubin. So by giving phenobarbital, you can ramp up the production of those enzymes. And we'll go into that more detail in those videos. So now let's compare barbiturates to benzodiazepines, which we actually use a lot more often, because they are both used for sedation and anesthesia, and they work in similar ways. Now, there are tons of different benzos out there, and most of them end in either azepam or azalam. So there's diazepam, there's lorazepam, alprazolam, there's a ton of them. Now, midazolam is one that is very commonly used for conscious sedation in short procedures. So remember midazolam, or you can also use it to sedate someone before you take them to the OR and start that general anesthesia. Now, there are longer-acting benzodiazepams like temazepam, often commonly used for insomnia. It lasts a little bit longer. Also a good nighttime interval dosing. Another long-acting one that's classically used for alcohol withdrawal is that chlordiaze epoxide. So again, benzodiazepines have a very similar mechanism to the barbiturates, but there is a difference. Instead of increasing how long the GABA receptor chloride channels stay open, they increase how frequently the chloride channels open. But the end effect is actually the same. Now, you're potentiating GABA and increasing the effect of that inhibitory neurotransmitter. And though it's a bit on the sexy side, many students have written in with a mnemonic, Ben likes it more frequently, Barb likes it to last longer. Just another way to remember, barbiturates increase the duration, benzos increase the frequency of chloride channel opening. Another one that I personally like a little bit better is that people like the bars to stay open longer. So bars, barbiturates, that sort of thing. Now, benzos are really useful in anesthesia because in addition to some sedation, they cause amnesia as well. So we said that this was one of our 3 goals of anesthesia, amnesia, analgesia, and the immobilization. You don't want patients to have any memory of what's going on during surgery because it's kind of scary. But besides conscious sedation and anesthesia, we use the benzodiazepines for a lot of different things. We use them for alcohol withdrawal, anxiety, to stop seizures, to help with insomnia. But you should also know that while these drugs do help patients feel drowsy, essentially they're going to sleep, it's actually not permitting the normal brain activity of sleep. If you were paying attention during that sleep lecture, you remember that benzodiazepines decrease stage N3 of sleep, which can actually be pretty helpful if you want to decrease sleep terrors. Now, one problem with benzodiazepines is that they can be abused, and there's a big problem with dependence and addiction, and you don't want to mix benzodiazepines with alcohol or other sedatives. But actually, they are generally a lot safer than the barbiturates overall. It's pretty hard to put yourself into a coma or even kill yourself with benzodiazepines. But you definitely need to know this. What is the reversal agent for benzodiazepine toxicity? The reversal agent is flumazenil. However, clinically, we don't use this very often because flumazenil might actually trigger a withdrawal seizure, especially if that patient has been abusing benzodiazepines for a long period of time. Most of the time, we just allow the effects of benzos to wear off. So next, let's move on to opioids. Now, we said that we use benzos to sedate our patient and cause some amnesia. And then the second component of anesthesia is analgesia, or pain control. Now, we typically give opioids to achieve appropriate levels of analgesia, especially the potent IV opioids, things like morphine. We're using even more things like fentanyl, remifentanil, and sufentanil. And that's going to prevent the patient from experiencing any of that pain. So for conscious sedation, you might give midazolam plus maybe fentanyl. Mixing a benzodiazepine with an opioid analgesic, they're going to act synergistically. They provide a higher degree of sedation than if their effects were alone. Now, the opioids work by binding to opioid receptors. Now, the 3 receptors you should know are mu, delta, and kappa. Now, our bodies actually produce endogenous agonists to these different receptors, and you should probably know those as well. So at the mu receptor, beta endorphin is the agonist. At the delta receptor, you have enkephalin, that's going to be your agonist. And at the kappa receptor, it's going to be dynorphin. Now, one quick thing to know about fentanyl is that it doesn't induce the histamine release like morphine does. So morphine can sometimes cause a histaminic reaction. They get really, really itchy, and fentanyl really doesn't do much of that. Now, there are a few other unique opioids that aren't used in anesthesia, but you should probably know about them. So those butorphanol, that is a partial opioid agonist that causes less respiratory depression. We have dextromethorphan, a very, very weak opioid that's used as a cough suppressant, and it's over the counter. Tramadol is a less addictive opioid that can be used for pain. And then loperamide and diphenoxylate are used in the treatment of diarrhea, so they can really dry people up. Also important to remember that opioids can be reversed with the opioid receptor antagonists, naloxone and naltrexone. All right, so now let's move on to the neuromuscular blocking agents. So we've covered the amnesia, and we've covered some of the analgesia, and now that third component, we need to get immobilization going here. So to ensure immobility, we use a neuromuscular blocker. Now these drugs induce a state of chemical paralysis and should only be used in a patient who is unconscious because paralyzing conscious patients would be really, really frightening and dangerous. We also use neuromuscular blocking agents to facilitate endotracheal intubation as well. Now, there are two different categories of neuromuscular blocking agents. There are the depolarizing neuromuscular blockers, and there are the non-depolarizing drugs. Now, there's only one depolarizing neuromuscular blocking agent in clinical use, which is succinylcholine, but there are several different non-depolarizing drugs, so let's start there. So the non-depolarizing drugs are chemically related to a plant poison named curare. So this poison was used by indigenous peoples of South America by dipping arrows or blow darts into them, and then the prey, after it was shot, would have respiratory muscle paralysis, and then they would just die. So these drugs all sound like they come from curare. So there's one called tubocurarine. Some actually have a suffix curium, which includes the drugs like atracurium and mivacurium. And then there's another suffix, curonium, which include drugs like vecuronium, rocuronium, pancuronium. Now, each of these drugs is used at different times for different reasons, but be able to recognize the three suffixes, that curarine, curium, and curonium. Now, how do these work? Well, these are competitive inhibitors of the postsynaptic nicotinic acetylcholine receptors on the neuromuscular junction. So they compete with acetylcholine for that binding site. And when they bind to the receptor, they actually prevent acetylcholine from triggering a muscle contraction. So the muscle just stays nice and relaxed. But think about this for a second. How do you overcome a competitive antagonist? Well, you can increase the amount of natural agonists. So you can actually reverse a non-depolarizing neuromuscular blocker like rocuronium by giving a cholinesterase inhibitor, something like neostigmine, which will effectively increase the amount of natural acetylcholine at the neuromuscular junction. You're kind of overdriving it. The other big category of neuromuscular blocking drugs is the depolarizing neuromuscular blocker. And we said there's only one of those, succinylcholine. So how does it work? Well, succinylcholine is going to bind to those same nicotinic receptors on the neuromuscular junction. So it's also a nicotinic agonist, so to speak. But the difference is that instead of just preventing acetylcholine from triggering a muscle depolarization, the succinylcholine actually does stimulate those nicotinic receptors. So the muscle does depolarize, and you actually get a contraction. Now, clinically, you're going to see some muscle movements called fasciculations. Now, after an appropriate dose, those fasciculations will cease after just a few seconds, and then as the succinylcholine molecule remains bound to the acetylcholine receptor, neuromuscular blockade is actually achieved until that succinylcholine molecule moves away from the acetylcholine receptor and then is degraded by serum pseudocholinesterase. So this takes maybe about 10 minutes. Now, succinylcholine can cause two different types of block, which are clinically important. There's something called a phase 1 block. So this is a type of block that you get when you administer an appropriate dose to a normal patient. And a phase 1 block has a very rapid onset, goes away in again about 10 minutes, just as mentioned. Now, a phase 1 block cannot be antagonized and has very unique characteristics when using a twitch monitor to verify the degree of muscle relaxation in a patient. If a patient receives a large dose of succinylcholine, you can get a phase 2 blockade. Now, this block has characteristics that are very similar to those of non-depolarizing muscle blockers, and a phase 2 block can also be antagonized by using acetylcholinesterase inhibitors, things like neostigmine. Importantly, a phase 2 block can last from 20 to 30 minutes up to a few hours. Then one last thing to mention about succinylcholine is that the potential for malignant hyperthermia. So malignant hyperthermia is a condition where you have muscle rigidity and hyperthermia, so high temperature. Now, if you give an inhaled anesthetic with succinylcholine to a susceptible patient, specifically a patient with a mutation of the RYR1 gene, which is a gene for skeletal muscle ryanodine receptor. So if they have that mutation, then the succinylcholine can cause malignant hyperthermia, and it's pretty rare, but unfortunately pretty dangerous. So if you have a patient with a history of malignant hyperthermia, you would avoid using succinylcholine in the first place. You'd reach for a non-depolarizing neuromuscular blocking drug instead. But if you did give succinylcholine and they did actually get this problem, then your treatment is to cool that patient down. You're going to sedate them, and then you need to give them dantrolene. And you're going to give that dantrolene as quickly as possible. Dantrolene is a drug that prevents the sarcoplasmic reticulum from releasing calcium, and that's going to lead to more relaxation of the muscles. Now, we use it also to treat malignant hyperthermia and also neuroleptic malignant syndrome, which is somewhat similar as well, and it's covered in psychiatry. All right, so that's it for the neuromuscular blocking drugs and the general anesthetics. Now let's talk briefly about the local anesthetics. So local anesthetics, whether it's things like lidocaine, procaine, even cocaine, they all work by blocking sodium channels. So sodium channels are the workhorses of the neurons, allowing them to depolarize and fire. Blocking these channels impedes the ability of neurons to reach their threshold and then fire off. But there are a few important concepts to understand about local anesthetics. So first of all, they don't all work very well in acidic tissues, and that includes things like infected tissues. So if you're draining an abscess with a scalpel and you're trying to open it up and you're trying to anesthetize the area, then you want to inject a local anesthetic, maybe a small distance from the infected tissue, or just use a lot more of it, which again has an acidic pH. The acidity of that infected tissue ionizes the local anesthetic molecule, making it unable to pass through the neuron cell membrane and thus unable to bind and block that sodium channel. Now, another principle of local anesthetics is that small diameter nerve fibers and myelinated nerve fibers are more susceptible to them than are the large diameter and the unmyelinated fibers. And the size is more important than the myelination. So the first thing you're going to block are the small myelinated fibers, then the small unmyelinated fibers, and then the large myelinated fibers after that. Now, so it turns out that sensory fibers tend to be the small diameter nerve fibers, and clinically this results in the ability to block pain at low dosages there. Now, the sympathetic nervous system contains medium-sized nerve fibers that are myelinated and require slightly larger doses to see a full block there. Now, lastly, motor nerve fibers are the largest of all and are very myelinated as well. Therefore, clinically, in order to get complete motor block, you need a much larger dose than you would in order just to get a block of pain neurons. Now, the other principle of using local anesthetics is that we tend to give them with a local vasoconstrictor in certain parts of the body. You wouldn't want to give this in something that is a terminal organ. You don't want to give this in fingers where there's no collateral circulation because you can cause ischemia. But in tissues that have collateral circulation, you can give a vasoconstrictor such as epinephrine with your local anesthetic. And the reason why you would do this is to decrease the rate at which the blood carries the lidocaine away and to decrease bleeding at the site as well, because they're going to be cutting into it. So if you give lidocaine with epinephrine, the epinephrine will make those local vessels kind of clamp down and you're decreasing blood flow to the area. So you won't need as much anesthetic and it will last longer in that area as well. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own and then we'll go through them together. All right, first question, which anesthetic fits each of the following descriptions? So first we have IV associated with hallucinations and bad dreams. That's going to be ketamine. Next we have IV, most commonly used benzodiazepine for conscious sedation. Think midazolam. Next we have inhaled side effect of hepatotoxicity. Remember that one is halothane. We don't use that one anymore. IV for rapid anesthesia induction and short duration of action. Remember that's going to be propofol. IV decreases cerebral blood flow, important in brain surgery. That one might be a little bit tough for you. That's going to be that barbiturate thiopental. Next, we have opioid that does not induce histamine release. That's fentanyl, not quite as itchy. And high triglyceride content increases the risk of pancreatitis with long-term use. That's going to be propofol. Next question, what is the mechanism of action of dantrolene? So remember that dantrolene is going to prevent the release of calcium from the sarcoplasmic reticulum of that skeletal muscle. It's going to relax those muscles. Next, what is the mechanism of action of local anesthetics? Remember, they block the sodium channels. And then which nerve fibers are blocked first with that local anesthesia? Remember, it's the small myelinated, often pain ones, and then the small unmyelinated, then the large myelinated, and then the large unmyelinated. Next, Last one here. What drugs can we use to reverse neuromuscular blockades? Remember, it's the cholinesterase inhibitors. Things like neostigmine is the prototype drug that's used for this. And remember that only for neuromuscular blockade with a non-depolarizing drug like tubocurarine or vecuronium. All right, guys, that brings us to the end of our video here. I hope you learned something. I'll see you next time.